The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr. David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, a doctor's eyes are failing them.
That's probably something that you would use your authority to say that this does need to be done.
That's Dr. Rupert Sherwood, Deputy Chief Medical Officer and Acting Director of Obstetrics and Gynaecology at Western Health. And I'm presenting him with a difficult scenario.
It's a threatening situation which has evolved over a period of time.
Today, being able to see a problem. In this scenario, a 54-year-old gynaecologist, a popular consultant considered to be safe and solid, has been working in your hospital for more than 20 years. For the last couple of years, however, they've been suffering from what is probably progressive macular degeneration and have become reliant on the help of a clerical officer for administrative tasks and writing up their clinical notes. They've also been struggling with adopting the new electronic medical records system. A new nurse in the clinic has raised concerns that this doctor is slow and unable to get through a normal clinical list. And the nurse also expresses concern about the doctor's reliance on the clerical officer who they believe is becoming involved in clinical decision-making. Dr. Rupert Sherwood starts by describing the general issues raised.
First and foremost, of course, is patient safety. And the first thing I'd be wanting to sort of know is, has there been a specific trigger, or is it just the nurse is new to the unit and has noticed something that's been well tolerated in a system? And this certainly happens because, in this case, if that is the underlying diagnosis, then it's been slowly progressive and not a sudden change in vision and or ability. So there's a couple of triggers here that I'd be wanting to explore. One is to further explore the concerns of the nurse and whether they're shared by other people. And secondly, the transition to the electronic medical record. Has that been a specific trigger, or is it just another additive factor?
So I guess one of the first things to do is to confirm the doctor's diagnosis. How involved can you get in the medical diagnosis of your medical staff?
As an administrator, really only as a facilitator, but that's an important role because the suggestion, perhaps, say from a colleague or even the nurse, that perhaps you're concerned about their vision, have they checked with their GP or have they had an eye test lately? It may be seen as both intrusive and an invasion of their privacy and may be sort of just brushed off or cause upset. So as an administrator, if this specific problem has been identified, and there may well be other problems underlying here as well, although in a person in their 50s, one would be less concerned about some of the things like cognitive change and things. But the role of the administrator is to be fairly direct in requesting an assessment. And that's probably something that you would use your authority to say that this does need to be done. You do it in a gentle way at first, but you make it clear that it's not negotiable, and then support the person through that. And often you'll find they might agree to some sort of test, and you check in 2 or 3 weeks later and they haven't actually made the appointment. So again, it's that collegiate, supportive, but clearly coming with some authority to get this process started.
There's lots of people involved and issues around a doctor who's performance is deteriorating or compromised. You've got the nurses that work with them. You've got their peers as specialists. You've got the patients that they're looking after, but you've also got the specialist's family, their spouse or partner, their children. The fear that it may compromise or restrict their ability to earn an income for the next 10 or so years. How do you work with all of these different stakeholders?
It is complex, and it's particularly complex when the disability or change in ability has been progressive over a period of time, such as in this case. So a very different scenario, your well-functioning doctor has an accident or a stroke or a heart attack. Clearly an event that can be in the public domain, and clearly everybody's sympathetic to the need to change the role and things. But in this situation, limitations on the role has come on slowly, and there's been adaptive change within the working environment. I think that you need to work initially very much through the practitioner themselves, explaining that there is an issue, that we are going to need to address it. And I'd be saying to this very senior, respected specialist, how do you want to manage your colleagues and the people who are going to be affected if we need to either change your practice or take you out of practice for a while? From the family point of view, again, I think then that's much more personal with the specialist, and I'd be advising them to seek help, seek advice from their general practitioner. You can't second guess the relationship of someone in their 50s who may have a long-standing partnership with another person as to how that's going to be dealt with, and I wouldn't be stepping into that part. I would be more looking at the effect on our workplace.
One of the challenges, as you've pointed out, is you need to talk to the doctor. What background information would you want to collect before you approach the doctor themselves?
That's a good question, because you can go about this in several ways. You could take the approach, okay, I've had a concern raised by a new nurse who's senior enough to recognise there may be an issue. I'll now go about doing a bit of data gathering. I'll talk to some other people in the clinic, perhaps to some colleagues. I'll have a look at a few records. That approach risks being seen as being sort of working behind the doctor's back. They'll likely find out that you're being asked these questions. So the second approach is to actually just take the concern on face value, unproven and not backed by any evidence, and go to the specialist and say, look, a member of the staff whose opinion I respect has raised some concerns. I'm coming to you first. And then I would proceed based on the response I get, and which could range from, look, I've been worried about this myself. I just haven't known what to do about it. Thanks. I'm really pleased you're going to give me a hand with this. To anger, get out of my room. I don't want to talk to you. You're just an administrator. So as a senior administrator, you have to be able to manage all these scenarios, and there's no particular playbook for this. My preferred approach would be to go to the specialist first, because even in a big hospital, there's communities within communities, and this doctor works probably within a small community within the big hospital, and it'll soon be apparent if you're having a look at a few of the records, particularly with electronic medical records. Of course, whoever looks at records that's tracked, the doctor might see next time he opens up one of his patients that you've been looking at the file, and as simple as that, ask you, why were you doing that?
You raised early on the issue of patient care and patient safety. How can you tell whether this doctor is still providing high-quality care to the patients that he sees?
Well, it's a fraught problem, because the usual monitors and tools are, as you know, fairly blunt instruments, particularly, let's say, in the ambulatory setting. If we were in an operative setting, then you might have had some flags in terms of operative outcomes, the usual triggers, return to theatre, complications, blood transfusions, things. But in the ambulatory setting, where someone's giving advice, booking or not booking operations, it is more difficult. And some of the things you might get concerns raised by colleagues, as we've had in this case. You might get changes in efficiency and output, and that can certainly doesn't affect the individual patients, but it affects the overall care of the unit. And you might have had some feedback about inappropriate management, concerns sometimes from GPs. If the specialist is putting people onto a gynaecology waiting list in this case, inappropriate case selection and flags like that. The outcomes in terms of technical things in an outpatient setting are fairly limited. I mean, they're probably not even doing minor procedures, maybe involved in IUD management, pessary insertion and things. So not things that are going to flag in the standard safety and quality environment.
When do you consider supervision and peer review?
They're not initial steps, they're steps down the line. Peer review is something that's obviously agreed on with the specialist, so that's after acknowledgement that there may be an issue, and that can be part of delineating the problem, and that's really what peer review is. Supervision, very different matter, and that's part of the end point where you've agreed that there may be an issue, and that supervision is required to ensure that remediation is taking place successfully and that harm is being prevented. Peer review can certainly occur with a senior specialist. Supervision's more likely something to be put in place in an early career specialist or a specialist who's trained in another setting where there may be things, cultural issues and technical issues that we want to observe. But supervision would probably be a less likely option with a senior specialist.
We've got the scenario where the specialist is aware that their eyesight's a problem and they've been relying on the clerical officer, a non-clinical person, to help them out. They've probably been working with this person for many years and developed trust and confidence in their assistance. Is it appropriate for a clerical officer to be helping a gynaecologist in delivering clinical services?
In general terms, no. But again, this has almost certainly evolved slowly over a number of years. So minor assistance at the beginning would have been seen as acceptable by all parties, and it's gradually probably increased to a point where it's likely crossed the line where it's not acceptable. I mean, the writing of notes by a non-clinical person is fraught with medico-legal risk, and interpretation of referral letters, reading them and things like that also carries significant risks. So I think that definitely needs to be explored. And one of the questions that early in the piece, in my initial conversation with the specialist, would be to inquire as to whether there are any background reasons as to why they hadn't addressed the issue of failing sight, or if they had a specific diagnosis why they weren't availing themselves of some of the current therapies. They may have a colleague who'd had a major complication of the accepted therapies. They may fear other aspects, such as losing their driver's license and other forms of independence. So there's all the things are interrelated. We're only seeing, as we do with a lot of impaired medical practitioners, we're seeing one part of what is a much more global picture within their life.
So what are the employment options for this doctor as their eyesight continues to deteriorate?
Limited in a complicated specialty such as gynaecology, where good vision essentially is going to be part of what you do. Even sort of non-clinical aspects, safety and quality, teaching things, that they're all still fairly dependent on good vision. So it is going to be limited, and I think this then speaks to the reason why it may not have been addressed, because of these significant threats and potentially the limited ability to correct this disability. So it's a threatening situation which has evolved over a period of time. Some workarounds have obviously been put in place. The doctor themselves, by your account, sounds like a popular, might be the right word, but a respected clinician. So often the other things will be tolerated to a higher degree than someone who is malfunctioning in other areas, so is rude and abrasive and the patients don't like them. Their lack of ability or disabilities would be noticed earlier probably. So this is the situation which is a little bit more difficult because of the popularity and the respect in which this doctor's held. That may affect how they respond to you, or their response still might be to be quite upset, even though that they're known to be someone easy to get on with and amenable to things. I wouldn't guarantee that makes your pathway to helping this to be easy.
If you decide they need a physician's assistant or a nurse practitioner to be their eyes and ears, allowing them to continue to use their extraordinary knowledge that they've developed over 20, 30 years and still deliver safe care, who should pay for the assistant?
I think if you were able to, may be difficult to fit into this scenario, But if you were to do that thing, that's a decision that's going to be made by the hospital. So that's really going to be a cost-benefit analysis as to continuing the care provided and providing someone to help with that. Now, keeping in mind that one of the issues that's been raised is a drop-off in efficiency and productivity by this practitioner because of their reliance on other people and their disability with their eyesight. Whether that, then obviously in just simple management terms, you're actually going to reduce that efficiency and output further by having an assistant and paying an assistant. The plus of having a clinical assistant is that you can set some clear guidelines and you are much better positioned medico-legally. From the patient point of view, you might find that there's some resistance to that because, of course, the patients may not be aware. Your average patient only visits a specialist once or twice. They don't know how long it's meant to take or whether a nurse is meant to be writing the notes. So they may not have perceived anything's wrong. Once you formalise this, I think I would say you're obliged to include it in the sort of outline to the patient as to what service they're providing, particularly as they may say, my aunt came to the hospital, saw someone else, they didn't have a nurse helping them. Why the difference? So I think you've got to be open and transparent about this. It also requires a significant step on behalf of the specialist to acknowledge formally they need that help because likely there's been an element of denial about the degree of help that they're receiving. It's particularly, again, I come back to the fact that it's just gradually come on over a fairly long period of time. The other thing about that change is that there is a displacement of the status quo. And there's no doubt that this specialist and the clerical person who's helping them have probably developed quite a strong professional relationship. And the clerical assistant who's doing this would probably feel they're doing the right thing and would likely feel quite put out when that role was ceased and replaced with someone else.
So you look back and realise that this gynaecologist has been hiding, missing, perhaps fudging some of their clinical assessments, and you think patients have missed out on the care that they should have had. How do you go about remedying that concern that patients may have missed out or not received appropriate care?
You do have to address that. It's easier not to address it, and probably no one would know if you didn't, but you actually have to, you're obliged to. Sometimes these sorts of retrospective reviews are triggered by a significant event, but other times it's realising that someone has a disability. Often it's a formal recognition of cognitive impairment or something like that, but in this case it's a systems issue with their eyesight. You would have to actually do a retrospective chart review, independent. I'd actually probably not use colleagues within the hospital. I would actually, as an administrator, I would seek an expert opinion, which I'll have to pay for, from an experienced gynaecologist who doesn't have any conflict of interest with the specialist. I do a chart review. So that's one step. The next thing, it may have been your next question, is what do you do with the results? And you actually have to act. You have to act on the results. And this is where it becomes quite uncomfortable, not only for the clinicians, administrator, but as the hospital generally as a public relations exercise, because once you start doing a recall of patients, there are some things that are maybe not too high an impact on the patient's well-being. There may be patients who've had missed diagnoses of treatable cancers at the really serious end. I would, as an administrator, once I'm undertaking that process, I would be involved in my public relations part of the hospital, and clearly informing our insurer too. If you've recognised that your risk has gone from something that as yet caused no harm and you're going to put some mitigation in place to one where you are fairly concerned that there's been harm, and then after a chart review you know there's been harm, then that's very much a formalised process after that.
Rupert, I raised the question earlier about confidentiality, protecting the privacy of the specialist. But you've got a nurse who's raised concerns. Clearly, his peers have also had concerns and doubts. How much of your investigation or findings can you share with other people on the team?
It's fairly limited. You've really got to respect the rights of the practitioner with whom you're dealing. So I would make every effort to manage the confidentiality. Now, that's the formal confidentiality. Now, we know within a unit that there will be talk and it'll be recognised that Dr. So-and-so isn't doing their clinic for a while. So again, I think this is where the importance of early on establishing the relationship with a specialist as essentially their professional line manager, so as a chief medical officer or director of medical services. And part of that conversation is discussing this issue of confidentiality and reassuring them that all the formal steps for confidentiality certainly will be maintained, even to the point where the chart reviews, they should be de-identified for practitioner and patient details. It's really the age and demographics that the reviewer needs. But knowing that there's going to be supports required, and while they may not be provided by you yourself as the administrator, you are responsible for ensuring that those supports have been offered. Now, again, it's tailoring it to the needs. So, hospitals have employee support programs and such, but they might not be appropriate for a senior clinician who's been part of the hospital for 30 years. There may be a specialist in an unrelated specialty who may be able to help you in this regard in a sort of a mentoring support role, and you can be the facilitator for that. And obviously the patient's general practitioner. But there is potential for harm in these situations. But because we can't let that potential for distress and harm in the specialist practitioner override our obligation to the patients who have sought care prior to us starting this investigation, and those who may continue to receive care if we do nothing.
I guess that raises the difficult and challenging issue of when do you report this person to the regulator?
It is indeed challenging. I think this is a very contemporary subject. The recent publication on the outcome of APRA investigations and the effect on medical practitioners is very much to the forefront of our minds at the moment. My concept of mandatory reporting is the risk of ongoing harm. So the historical issues we are going to deal with, and then of course, if on a historical review egregious acts were discovered, then they're also reportable. But if you put in place some controls immediately, then I don't see the need to inform the regulator immediately. My approach to this would be actually to discuss this very openly with the practitioner, because of course you can self-report to APRA if you need, and that's sometimes better. But once APRA is involved, for better or worse, the process is quite slow. And the issue of the restrictions or investigation notes being placed on the public website strike fear into any medical practitioner. So it's a difficult one, but if I felt that I had contained any harm, then I would be comfortable holding off on APRA reporting. But it would be one of the topics I would discuss because it will be in the mind of the specialist. They will be thinking, is he going off to his office to report me to APRA? So it's a subject you discuss. And I will add, despite that I've sort of indicated that one wants to take a semi-formal approach to this and a supportive approach, that is not to say that you don't keep very detailed notes of your interactions and discussions with this practitioner right from the start. And again, I would inform the practitioner that that's what I'm going to do. I would invite them to keep a record and notes of our discussions for their own records. And I make the notes I make in discussing with someone, I make them in a form that, assuming that the practitioner would be able to read them at some stage.
It's so dependent on the doctor. As you said right at the very beginning, if he sits down and says, yes, I'm struggling, help me, patients can be quite safe. If, on the other hand, he says, get out of my office, you've got no right to challenge me, it creates harm for patients.
Yeah. The issue at hand, as I mentioned earlier, may not be all the issues. And you mentioned the threat to livelihood and things. And so there's often other background factors as to why someone doesn't want to change their work practice or have their work restricted. And in the work I did in 2018, the leading barrier to smooth transition to retirement that was restricted to surgeons, but the leading barrier was financial. And after that, it was loss of identity and loss of status. And we've taken the scenario of someone in their mid-50s who would be, in that sort of 2 decades of sort of peak earning ability. So significant implications, not only for the present, but this practitioner presumably was thinking that they probably had another 10 years of full-time work ahead of them. It's a very significant threat that this poses to them. And that's not to negate what we're going to do, but we just have to be aware there may be other factors we can't We don't have the right to explore them at the time of the initial discussion, but a good administrator will keep that door open and follows through on a sort of a throwaway comment, perhaps by the practitioner, about some other difficulties in their life, give them opportunities to talk about that, and then that then flows on to what other supports you might suggest for them.
Thank you, Rupert. Extraordinarily difficult situation where you've got friends often that you know well whose clinical abilities are being compromised, and yet, as you say, they're people with expectations, dependencies that have their own emotional and professional implications for your decisions. I'd like to thank you for your insights in our discussion this afternoon on what is a very challenging topic.
Thanks, David. It's been a pleasure.
That was Dr. Rupert Sherwood, the Deputy Chief Medical Officer and Acting Director of Obstetrics and Gynaecology at Western Health. That brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.